All right, we're going to get started. My name is Josh Wynn. Little bright. I want to thank you guys for coming to today's Lunch and Learn. Little upcoming events and housekeeping announcements before we get started. Buckeye Wellness offers several group fitness classes here at the medical center and also on campus. So if you're interested in Zumba or Strong or yoga, please see these dates here on the screen. You can sign up at yp4h.osu.edu to see all of the schedule. If you haven't done your PHA or have not completed your biometric screening, you can see Dixie outside, as well as the Comprehensive Cancer Center has information on mammography scheduling as well. Reminder, if you did not pick up an eval on your way in, please do so. We use that. Yes. Yes, sorry. All these classes are free. They are open for faculty, staff, students, alumni. If you have any relation to the university, you can access these classes. So, great question. If you haven't picked up an eval on your way in, please do so. We do take those seriously. This Lunch and Learn was actually based on part of the evaluation. So, please fill that out at the end. I want to introduce our speaker today, Dr. Sagar Sardesai. He has been a breast medical oncologist and assistant professor here at The Ohio State University since 2016. His research interest is in women who are at high risk for breast cancer and ovarian cancers, as well as the correlation between breast density and obesity in healthy women. He is a reviewer for multiple medical journals and has been rated in the top 10% of physicians in the nation for patient satisfaction. So please give him a welcome. Thank you.
Thank you, Josh. That was a great introduction, and thank you all. So today we'll be talking about exercise and the impact of physical activity in reducing breast cancer risk, as well as improving breast cancer mortality. And this is sort of a 30,000-foot overview of what the data shows, more so epidemiological and observational studies, and a few smaller randomized controlled trials. So the objectives of this discussion, I have no disclosures. The objectives are talking about weight gain and obesity and the risk of postmenopausal breast cancer. Physical activity in reducing the risk of breast cancer, but also helping women breast cancer survivors in terms of quality of life and on breast cancer mortality. And really thinking of exercise as a prescription that we are seeing gets benefit very close to some traditional anti-estrogen therapies that we've been discussing with women with breast cancer. It is dose dependent. The frequency and duration are something that's been investigated further, but really thinking of exercise more as a prescription with little to no side effects for our patients. We'll go over some other risk factors, and the reason I wanted to do this was really to show how complex it is to estimate an individual woman's risk of having breast cancer in her lifetime. We come across these several guidelines, ACS, ASCO, USPSTF, and they recommend mammograms starting at different ages. And it's always where we see patients who are perplexed, when do I start my mammograms and when do I start with my screening? And I think that's so individual because of several risk factors that have been associated with the risk of breast cancer. And then shortly just talking about our high-risk program here at the OSU Comprehensive Cancer Center for women who are higher than average risk for getting breast cancer in their lifetime. So this slide perhaps many of you have seen before. This is SEER data showing that breast cancer still is a pretty common cancer, 1 in 8 women in their lifetime. And 29%, roughly I would say about 240,000 new cases diagnosed annually, still represents the second most common cause of mortality from cancer in women in the United States. And there are several non-modifiable and modifiable risk factors. Non-modifiable risk factors have a lot to do with family history, genetics, age, gender. But the two most important modifiable risk factors are body weight and physical activity, as far as the observational study data and epidemiological association. So the WHI randomized trials were a set of 3 major studies that looked looked at several endpoints, but about 67,000 women who were enrolled in the study, and this was prospective data, and published recently in 2015 by Dr. Klobowski's and the other colleagues, looked at obesity and especially weight gain leading up to the years of menopause as a risk for postmenopausal breast cancer. And if you look at this first table, when you look at the subtypes, this hormone receptor positive. Now, breast cancer is made up of several different subtypes. It's really heterogeneous, but to broadly categorize breast cancer, there are three main subtypes: ER positive, ER negative, and then HER2 positive. So it was the estrogen-driven or hormone receptor positive breast cancer that had the strongest association with obesity or with weight gain. And it ranges, it has a linear relation with the BMI. So as the BMI goes up from 25 all the way to 35, the risk of postmenopausal ER-positive breast cancer goes up to as high as about 1.8 times or 80% more likely than women who have a normal BMI. For women who had the normal BMI of between 20 and 25, we saw that those women who gained about 5% body weight had a significant worse outcomes in terms of their breast cancer risk. And that's what is highlighted in red here. They were about 36% more likely to be diagnosed with postmenopausal breast cancer, despite being in that normal BMI range. So this comes along with several other studies that have shown a similar association. I just wanted to highlight the WHI data, which probably has the largest sample size. And in the same study, weight loss was also looked at whether losing weight was actually protective. There are several studies that have shown association of obesity and weight gain, but really does losing weight after you have a certain BMI, does that impact your risk of getting breast cancer? And this was again in the same population, and you see that women who had a weight loss of more than 5%, whether it was intentional or unintentional, did get a modest benefit, roughly in the range of about 10 to 12% reduction in their risk of postmenopausal breast cancer. So this is an interesting, it has to do with how Americans or how the United States perceive obesity as a health problem or weight gain as a health problem. And this is, again, data-based, more so retrospective, but about 39% agree that obesity is an epidemic and it's a health problem for the United States, along with cancer coming the next. And most of us now feel that HIV is going down and not perceived to be such a high risk for the United States. But these graphs here on the right actually talk about what we believe in terms of how we see ourselves and our kids as being overweight and what the actual data is on the bottom. So in 1965, if you look at the overweight population, it was about 38%. 38% of Americans saw themselves as overweight, when the actual data showed that about 46% were actually overweight, so slightly higher. But in 2014, there's a big discrepancy. About 40% of us feel that we are overweight, but there's 69% of us which are actually overweight based on CDC numbers. And the same goes as far as perceiving weight gain or obesity as a problem in kids or young adolescents, where about 12% of the population believes that or perceives their kids as being overweight, but the actual numbers show something else. The NCI and the ASCO, both oncology-related cooperative groups, released statements suggesting that obesity will soon replace tobacco as the leading modifiable risk factor for cancer overall. And they suspect that we will probably go through the same stages of obesity like we went through the smoking epidemic. And right now we are at what they would refer to as stage 2, where we are seeing a peak, a rise in excess body weight, but we've not reached the peak death rate, which is what you see on your right. But as we start talking about this issue, and there are ongoing nationwide and statewide initiatives to bring excess body weight under control, we'll sort of see our death rates peaking and then falling off. So we are still at the stage where we are not seeing as high death rates from obesity, but we'll probably start seeing more in the near future. And it's not just breast cancer. I think when you look at oncology overall, there are several other cancers that have a very strong association with excess body weight. So colorectal cancers, uterine cancers, as well as pancreatic cancers, and they all make up to the top 10 list as far as the incidence of cancers overall in the United States. And there's strong data that weight loss actually helps with a lot of these cancers, especially colorectal and uterine cancers. So what about exercise or physical activity? And I specifically put down those two words separately because many patients perceive exercise as being as where you're consciously making an effort to exercise, but it does not always translate that you need to do such activities to really get the benefit. This has been studied. Recreational activities or even household activities can count towards what you're doing in terms of physical activity to to prevent the breast cancer risk or impact breast cancer mortality. So physical inactivity is also pretty common, reported to be at 38 to 40%, and it's typically defined as less than 1.5 MET per hour per week. 1.5 MET hour per week is one MET an hour is where you're sitting for an hour without doing anything. So that is what we would define as physical inactivity, and that seems to be as prevalent as 30 to 40% in the United States. Physical activity is protective irrespective of your baseline body weight. I think that's, again, such a key message that it doesn't matter if you lose weight, although your goal might be weight loss, but physical activity in itself is an independent, has an independent protective benefit in terms of reducing the risk for postmenopausal breast cancer and also premenopausal breast cancer. So sometimes it's demotivating to see that your weighing scale not really showing a big change, but your physical activity in itself is actually protective. And this effect in terms of overall magnitude, if you look at all of the studies that have been done, some of them are randomized controlled trials looking at about a 12 to 15% benefit in terms of risk reduction. And this effect is dose dependent. And again, several studies showing that if you were going up from 3 MET per hour, which is roughly about 4 hours per week of brisk walking, going up from that to moderate to vigorous exercise, which would be about 7 to 8 MET per hour, would increase that benefit from a 5% risk reduction to almost a 12 to 15% absolute benefit in terms of risk reduction from breast cancer. And the same has been studied in patients who are cancer survivors. And this data is, again, in breast cancer survivors with pre and post diagnosis. And the second and the third bullet point here on the right, which talks about this dose dependency and frequency, with each 5, 10, or 15 MET per hour week increase in pre or post diagnosis physical activity, there was a significant incremental benefit in terms of reducing total mortality among breast cancer survivors. And the numbers that you're seeing here, which is 7, 13, or 19, or 15, 28, and 38% risk reduction, are very similar to some of the drugs that we talk about for anti-estrogen therapy in women with breast cancer. So examples being tamoxifen or aromatase inhibitors. If you look at the 10-year follow-up with tamoxifen or aromatase inhibitors, the hazard ratios are very close to 38% or 40% risk reduction in the long term in reducing breast cancer mortality. Although there's a lot of this observational and epidemiologic data and some smaller randomized trials, there's not a lot of, we are yet, I would say, somewhat unclear in terms of the mechanisms and how physical activity and weight loss actually translates into this benefit. In breast cancer, for a while, there was the hypothesis that circulating estrogen levels go down as you lose weight and as you're more active was thought to be what was driving this benefit. But more recently, there's a lot of these things here in red, which is improving insulin resistance, decreased inflammation, which is typically seen with weight gain, and again, helping and epigenetic alterations that were seen in patients who were more active. So it's complex in our group and overall in the United States. I think we are very interested in knowing, perhaps understanding these mechanisms better to target the high-risk population and come up with better tailored treatments for these patients. And this slide sort of explains how it doesn't just help with breast cancer diagnosis, but really throughout the spectrum of prevention, treatment, and even following your active treatment. in terms of improving quality of life, in terms of improving symptoms such as neuropathy, lymphedema for patients who are going through their breast cancer treatment. So the ACS, ASCO, and NCCN all recommend that physical activity is beneficial for women with breast cancer or who are trying to actively reduce breast cancer risk. And the recommendation is for 150 minutes per week or 30 minutes 5 times a week of low to moderate aerobic activity, which could be brisk walking, or 75 minutes of vigorous intensity aerobic activity, or a combination of both. And we encourage that if you could include at least 2 strength training sessions per week, that would add to your physical intensity of the physical activity, which is dose dependent and shown to improve benefit. So a couple of studies that that are running nationwide and especially in the breast cancer realm is the Be Well study, and this is for patients with breast cancer. It is a large multi-institutional phase 3 study that's looking at the role of weight loss from a web-based platform where patients are randomized to receive this intervention through Dana-Farber Cancer Center. And the control group is where they'll be getting encouragement through magazines or brochures. But this is a way of seeing if we can sustain these interventions for about 2 years. And after 2 years, we hope that patients are able to continue with diet and physical activity. But a major focus has been on, now that we know that physical activity and diet are good for patients with not just cancer, but almost all chronic diseases, how do we make sure that it's sustainable for most patients? Because it's very hard and it's very individualized depending on each patient, their occupation, their family, their socioeconomic status, and it gets more complex. The second study that we are enrolling is the Alliance Metformin RPFNA study, and this is in the prevention setting, where women who have a specific risk for having breast cancer are randomized to the drug metformin, which has traditionally been thought as an anti-diabetic, but because of its effect in reducing weight, as well as its effect on insulin resistance, it has been studied in this patient population. So besides modifiable risk factor, we know that sex and gender are probably the most significant risk factors for a person to have breast cancer, family history being the next, and then prolonged estrogen exposure, which comes from early age of menarche, late age of menopause, having pregnancy after the age of 30, and hormone replacement therapy, as was studied in the WHI group of trials. In addition, exposure to ionizing radiation for secondary malignancies such as Hodgkin's or lymphomas or leukemias when you're probably in between the ages of 15 to 20, abnormal breast biopsies, even if they were benign findings, and then in consumption of moderate alcohol consumption have all been associated with the risk of developing breast cancer. And some benign findings which increase the risk several-fold, probably about 40 to 50% in a woman's lifetime, are these 2 findings called atypia, which could be atypical ductal hyperplasia or lobular hyperplasia. And these figures here talk about 5 and 10-year risks. And these numbers are very close to lifetime risks that we see with some genetic mutations such as BRCA1 or BRCA2. And then moving on to hereditary forms of breast cancers. There are several now that have been more probably the most well-studied are BRCA1 and 2, but a lot that has come up in the last 10 to 15 years. We consider that it would be appropriate to refer these patients to a high-risk program of genetics based on their family history, especially if there's family history of ovarian cancer, or there's at least 2 relatives with breast primaries, a male breast cancer in the family. If someone was diagnosed really young, before the age of 50, there are more than 2 family members on the same side with breast cancer, just breast cancer specifically, and at least 1 first or second degree relative with breast cancer under the age of 50. And some patients with multiple solid tumors that tend to cluster in some of these genes would be appropriate from a primary care perspective referral to a genetics or a high-risk program for further testing and surveillance. So knowing that risk factors are really complex, there have been several models that are trying to predict a woman's risk of breast cancer in her lifetime, and probably the easiest to practice in a primary care setting would be the Gale model, which roughly takes about 5 minutes to go through. all of the patient's personal history and family history. It is not ideal for patients who are DCIS, LCIS, ADH. This has been validated mainly in the Caucasian population. So we yet, I would say, and the Hispanic population, but yet don't have such strong data for African American ethnicity or others. And it's for a woman for her individual breast cancer risk, this again is a big overview, but not really specific in terms of family history. What can we do once we know that the lifetime risk for a particular woman is higher than average risk? And that has to do with increased surveillance of screenings, and typically can be doing more frequent screening in terms of adding a breast MRI to the annual mammogram for certain women who would need such aggressive surveillance. Chemoprevention, which is underutilized and has shown to have tremendous benefit in terms of reducing the risk of ER-positive breast cancers, which is the most common form of breast cancer. And there are several medications in that armamentarium. And then prophylactic mastectomy for certain women who have really high lifetime risk of breast cancers. So depending on your risk, the management can then be tailored depending on whether it's more screening or it's going to be chemoprevention or even talking about prophylactic mastectomy. So that's the reason I think it's important for everybody to know what your individual risk is and just not start mammograms at the age of 50, which is what USPSTF would recommend at this point in time. So the high-risk breast program at OSU has actually been going on for about 10 to 15 years. It was recently structured in the last 3 to 5 years, and I think the ideal patients to see in this clinic would be someone who has a more than an average risk. So a lifetime risk of 20% or a Gale model that comes out to be close to 3% and not just 1.67. Any family histories that we just went over for referrals for genetic testing. And options for these patients in the high-risk program are more aggressive screening, genetic counseling with geneticists, chemoprevention, lifestyle modifications, and then the options to go through clinical trials that we open for women who have a higher risk, such as the metformin study. And with that, I think the conclusions are obesity and physical inactivity are both independent risk factors for several cancers and other chronic illnesses, including heart disease, diabetes, and metabolic syndrome. Obesity is a known risk factor for postmenopausal hormone receptor positive breast cancer. Physical activity of at least 3 hours or 3 MET hour per week is protective in both pre and postmenopausal women, and as well as for breast cancer survivors. This effect is clearly dose dependent and is independent of your baseline body weight. Physical activity has shown to impact risk for both ER positive as well as ER negative breast cancer subtype. Unlike body weight, which has been shown a stronger association with ER-positive breast cancer. And risk reduction is close to 30%, which is these numbers are so close to certain drugs like tamoxifen and anastrozole. And we've also seen improved quality of life for cancer survivors and reduced likelihood of other adverse events such as sleep disturbances, mood problems, arthralgias, which are often seen with anti-estrogen therapies in that population. And with that, I think I'm ready for questions.
All right, do we have any questions?
Hi, is it working? I have 2 questions. One, you talked about BMI. So a lot of times BMI can be high if you have a lot of muscle. So looking at BMI versus percent body fat, is that different?
It is very different, and unfortunately, I wish we had a better predictor of body composition, which is easier to do in a clinic setting. They're looking at body composition with DEXA scans, which are, as we move ahead, I think the costs of getting a DEXA scan is going down. BMI is not the best predictor of body composition, and that is what is really important, which is the ratio of muscle to body fat. So someone who has a higher BMI because of muscle tissue is not at the same risk compared to a woman who has more body fat. And Andy Dannenberg at Sloan Kettering and his group have actually shown that patients who fall in the normal BMI category, about 15% of them are metabolically, we would say that they have the metabolic syndrome with insulin resistance, despite having a normal BMI, and this is specifically seen in the Asian and Hispanic population more than it's seen in the Caucasians, where we see a lot of, most of that population would fall under a normal BMI, but still has body composition where we would see a different waist to hip ratios. So DEXA scans are better predictors of body composition than a BMI, but are not practical in every clinic setting.
Can I ask one more?
Absolutely.
You talked about like physical activity. What's your opinion on standing desks? So a lot of us have standing desks at work now, so we're not sitting all day. But does it matter if you're just standing and not moving versus sitting and not moving?
So standing and not moving would only increase your physical activity by about 0.5 MET, which is still an increase in just, when you're sitting around at a desk. But what would be more useful is if you can take breaks and then, take walks or run down the stairs, which is what we need, I think, going up to that 3 MET per hour, which is where we start seeing the benefit from physical activity. At typically under 3 MET per hour, we would not be able to say that there is a significant reduction in breast cancer risk or breast cancer mortality.
Great questions. Anyone else? We have some extra time, so if you have any questions or comments.
Hi. Excuse me. I have a family member who had a double mastectomy and did radiation and chemotherapy and just started the chemo pill and the shots for hormone blocking. And her energy is really, really low. So is there obviously shown benefit even if she gets up from her chair or takes a walk around the house? Is that still beneficial for her as far as?
So I think that's a great question. Some of our treatments for breast cancer, we know that when you go through chemotherapy, radiation, and those pills and shots that you're talking about can drop your physical activity by almost 3 METs, and that's pretty significant. And that's what unfortunately our treatments do because of going through such a long year to year and a half of treatment. But and the recommendation is to get to that 150 minute per week, but there has to be a starting point. And I think it doesn't matter if you're able to get as much as you can. What will help is some supervision in terms of someone to monitor that physical activity, and that again leads to the resources that we can talk about here at the James, but or elsewhere. But it's hard to sustain that level of physical activity for say 2 years or more than 2 years for someone who's gone through those treatments, and that needs an exercise physiologist, a nutritionist who's able to work with that patient to get her to her goals.
I think there was another question.
Hi.
Hey.
You mentioned at the beginning just different timing that different providers would recommend the mammogram. So at what point should we start considering?
So I would say that for a woman who has an average risk, which is essentially if you don't have any significant family history, and you fit in the age where you would have normal estrogen exposure, which is starting at a normal age of menarche, expected normal menopause in the family, having children before the age of 30. If that I would say is most of our demographic population, which is changing as times change. But for those patients, I would say they're at an average risk, and that I agree with the USPSTF, which then starts at the age of 50, every 1 to 2 years. But if you're concerned about what is my lifetime risk, then the easiest way is to go through the Gale model, and that sort of gives you an estimate. And if that estimate comes closer to 2 to 3%, then I think that's higher than average, and that means that you would need to seek adequate counseling.
Any other questions, comments? Going once. Yep.
You made the comment in some of this about dense breasts. When you start mammograms early, and they call you fibrocystic, or then they call you dense breasts, and then, where does that fall in risk?
So breast density, so when you look at all the data that we have with breast density, it's specifically for perimenopausal women, so after the age of 40, if you're expected that at that age, it's expected that breast density will start falling down as the glandular tissue goes down and it's replaced by more fibrous tissue, or more fat. But if that doesn't happen and we still see a higher breast density, or especially in the upper quartile, which is more than 75% of the breast tissue is dense, then those women are at a higher risk of developing breast cancer, and early on, or before the age of 60 is what I would say for most of those women. What do we do with that data is still not clear, because the mechanisms of breast density and how it leads to breast cancer, as well as it's not really incorporated in most models yet in terms of assessing lifetime risk. There are newer techniques as we move forward with the 3D mammograms or tomosynthesis and whole breast ultrasounds, which are now trying to address this issue of density. But for women who have high breast density and who are perimenopausal and have other risk factors such as family history, here at, typically with our high-risk breast program, we would prefer to screen them additionally with either a whole breast ultrasound or an MRI.
Does our mammograms you get your mammogram results, it's just you're fine or you're not. You need to come back or you don't. But is it list density on it? Can we go back and look at our
Yes,
results, the whole report?
so it is mandated that your mammogram report should have the breast density and should notify the patient if you have a high breast density on your mammograms. And that's no matter where you get it done, it should be reported on your mammogram. If you have, typically it would comment as heterogeneously dense breasts and may need further screening. But that's something that's mandated by the federal government.
Anyone else? Once? Twice? All right.
All right.
Well,
Thank you so
appreciate it.
much.
Thank you so much.